Good afternoon. Thank you very much for the kind invitation. Sorry not to be able to join the meeting, neither physically nor not even online and on time. Anyway, I have recorded for you this lecture about sentinel node as a standard of care in the endometrial and cervical cancer. I'm Denis Keller. I'm currently working in Rome and in Strasbourg. I have no real conflict of interest. And I would like, for those of you who are not familiar, to detail what is sentinel node. Sentinel node is the first defense of the organism in many cancers, including endometrial and cervical cancer. And you see here that there is a channel, lymph channel coming from the organ, from the uterus in this case, and ending in a lymph node. And this lymph node is the first one to be likely to be involved. So it has a crucial role in the defense of the organism and, of course, in the diagnosis of spread of cancer. And the SLN concept is becoming very popular. The first reason is that it's a new approach. We are fed up performing huge lymph node dissection with complications with long-term lymphedema. And it logically refers to natural history of cancer, not in the Halstedian mindset, removing as much as possible, but removing as less as possible. Maybe more is less in this regard if we remove only the node which is likely to be involved. And in cervical cancer, it's the potential end of the obsession to miss a disease node, which is tragic, and also the hope to reduce the morbidity of lymph node staging. Endometrial cancer, it's a hope to close forever the never-ending controversy between the believers and non-believers in lymph node dissection. In the meantime, it has changed the template of pelvic lymph node dissection and drawing the attention. It's not new, but drawing again the attention on the need to remove the common iliac and the presacral node in the standard template of pelvic lymph node dissection. On the other hand, it has confirmed the possibility to omit the circumflex iliac nodes that are associated with lymphedema and are unfrequently involved isolately. The problem is that there are drawbacks. I will mention technical failures, I will mention the lack of equipment, and I will mention the failure to follow the proper surgical algorithm. Starting with the algorithm, it's a Memorial Sloan Kettering Cancer Center algorithm by which any suspicious node, even if not detected as sentinel node, must be removed, regardless of mapping. 2, excision of all mapped sentinel lymph nodes, real sentinel lymph node, one on each side, one or two on each side, have to be removed and ultra-staged, special pathological assessment. And 3, as the uterus is a medial organ, there must be a mapping on both sides, not only one sentinel node. And if there is no mapping on one side, a site-specific lymph node dissection has to be performed. There are 3 requirements, and it's the same that the fight against any virus disease, as you must be aware. What about experience and faulty technique? First point is that we don't have to remove too many nodes and we don't have to remove wrong nodes. And only the first node, the one which is linked to the first channel coming from the organ, this one and this one, have to be removed. There are always efferent channels going out of the nodes to other structures, and the other structures are not sentinel nodes. And the concept is that the channel is more important than the node itself. And you see here the blue channel crossing the umbilical artery going to the pelvic side wall. And in this case, the sentinel node that has been dissected and still attached to the channel. This is the ultimate proof that this is the sentinel node. Experience is extremely important, and you see here on the left side the learning curve for sentinel lymph node, which plateaus that is completed after 30 or 40 cases. And you see on this side that the percentage of what is called empty packets, empty nodes, removing something which is blue or which is green and is not a node. And it's a complication because we don't have nothing to assess, anything to assess. So we see here that the incidence of this faulty finding is decreasing with experience. Also, there is a technical issue. It's clear that we can do sentinel node with blue dye and or technetium, but indocyanine green is much better, and there is level 1 evidence in favor of this, and especially in obese patients. So it's better to be equipped with infrared fluorescence using indocyanine green. Other drawbacks, and they are related to pathology, to the small volume of the deposits of cancer in sentinel lymph nodes. Dedicated pathologists are absolutely crucial. And ultra staging, which is not standardized yet, is also crucial. The same is about frozen section. Dedicated pathologists only can do this. Also, there are uncertainties about the significance of the management of low volume disease because we discover many micrometastases, less than 2 millimeters, and even isolated tumor cells, less than 0.2 millimeter, with no available randomized study about the adaptation of adjuvant treatment to this finding. And even the significance of this finding is unclear, with a general agreement that micrometastases are more like macrometastases, and that most probably isolated tumor cells are not prognostic, but it is not that clear. And finally, some paracervical nodes that are found in the lateral to the cervix are not sentinel nodes. They are parametrial nodes, meaning parametrial involvement. Now coming to the clinical use of sentinel lymph nodes, starting with cervical cancer. I will give you only a few messages, rational, evidence, and guidelines. The rationale is not leaving in place a disease node. You see a very old picture. It's a lymphographic picture showing a lymph node remaining after a comprehensive lymph node dissection. If this node is a sentinel and if it is involved, it's a complete disaster. Also, using today the sentinel lymph nodes spares the patients in a minimum of 10% of patients a combined treatment with radical hysterectomy plus chemoradiation, because we don't use this traditional algorithm, definitive pathology, waiting pathology, just to decide after having performed radical hysterectomy in all patients. In the new algorithms, using frozen section, some patients will have sentinel lymph nodes, positive lymph nodes discovered intraoperatively, and will have aborted radical hysterectomy. So only aortic dissection, no radical hysterectomy, and will be given chemoradiation. And only the false negative patient of frozen section will have this dual combined treatment that adds morbidity to morbidity. And in our experience, we recently published, it's only 2% of patients. What is the evidence in favor of the use of sentinel lymph node is in early cervical cancer? One, we have known for years that bilateral negative sentinel lymph nodes predicts absence of lymph node metastasis. So it's crucial. Also, we know that ultrastaging is a tool to accurately identify low volume disease. It's not completely clear now, but in another study, Cervical 2, a reduction of the postoperative complication has been observed compared to full dissection. And now, oncological safety of doing sentinel lymph node only in early cervical cancer is being investigated in 2 studies. Centix is almost finished. We are waiting the result after having finished the accrual, and Cervical 3 is ongoing. For these 2 studies, for sure, we have to be very, very careful and demand sufficient power and long-term follow-up before adopting the policy of sentinel lymph node only, which is not timely. What are the ESGO guidelines stating? For stage 1A, figure 2018, you see here that sentinel lymph node only is acceptable option because the incidence of positive node is very low, and this is mandatory only in 1A2 with LVSI. In the other substages is not absolutely necessary. Regarding 1B1, 2, and 2A1, less than 4 centimeter cervical cancer, sentinel lymph node is strongly recommended with intraoperative assessment of the lymph node stages by further section. But still, the standard lymph node staging is full systematic pelvic dissection. In endometrial cancer, the same templates giving only take-home messages. First, the rationale is a trade-off between too much nodes removed, because when we do a full dissection up to the renal vein, we remove so many normal nodes, up to 90 normal nodes, with risk of surgical complications, especially maybe difficult in obese patients, with no demonstrated benefit of full lymph node dissection. We have 2 randomized studies that not demonstrate any benefit. And there are lymphatic complication with 3% of significant lymphedema, which alters the quality of life of the patient. On the other hand, doing nothing is not enough, but there is a low but the identified incidence of node involvement and a high incidence of aortic nodes when the pelvic nodes are positive. If we don't know what we are treating and how we have to give adjuvant therapy to these patients. And there is no reliable preoperative predictive factors. The most important predictive factors, including lymph vascular space involvement, are accessible only after definitive pathology. However, there is level 1 evidence of the use of sentinel lymph node in endometrial cancer. Again, bilateral negative sentinel lymph node predicts absence of lymph node metastasis. There are two prospective studies showing this. One in France, Santiendo, one in the United States, FIRES, and in a large meta-analysis, it has been shown that sensitivity of sentinel lymph node mapping reached 96% with a predictive value of almost 100%. And this is also true for high-risk patients. That's extremely important finding. And in the same way than in cervical cancer, ultrastaging is a tool to identify low-volume disease. But again, clinical significance is totally unclear. Oncological safety of doing SLN only is documenting in retrospective studies, and prospective studies are now ongoing. What are the ESGO guidelines stating? They are very recent. They are just published. This guideline states that sentinel node can be considered in patients with low and intermediate risk. I mean sentinel lymph node only because in this subgroup of patients, systematic lymphadenectomy is no longer recommended. So it's really a fantastic trade-off because we have an information, but without the risks and complication of systematic lymphadenectomy. On the other hand, in high intermediate risk and high risk patients, sentinel staging should be performed, but again, sentinel lymph node biopsy only is considered as an alternative to systematic lymphadenectomy. Some still perform systematic lymphadenectomy, but sentinel lymph node biopsy only is already an acceptable alternative because of the uncertainties on the benefit of routine comprehensive lymphadenectomy. So again, regarding endometrial cancer, pathological ultrasaging is recommended. Macrometastasis and micrometastasis are considered as metastasis involvement, while ITC is not considered an involvement. If a pelvic node is found to be positive intraoperatively, further dissection in the pelvis should be omitted. It's not necessary. We know what to do. Debulking of enlarged lymph nodes can be considered, and also when there are positive pelvic nodes, paraortic staging can be considered just to assess the paraortic area. So in conclusion, you see that sentinel lymph nodes has a huge impact, many applications in gynecologic oncology, in uterine cancer. And it has become one of the emblematic techniques that defines the gynecologic oncologist. It has the potential to reduce long-term effects of full lymph node dissection. It spares the patient unnecessary surgeries. Clearly, it improves the precision of staging. Precision staging is not precision surgery, it's not precision treatment, but that's the first step. And sentinel lymph node is the case in very early cervical cancer and in endometrial cancer. It can be used in case of controversy about the application of lymph node dissection. If safety of lymph node dissection only is validated in prospective study, in this case, there is a future for the management of breast cancer or a cutaneous melanoma model with application of adjuvant treatment on the basis of sentinel lymph node only. But it's not the case today, and the surgical management of early cervical cancer is still surgery plus nodes plus something. But in the near future, surgical management will be preceded by MIS procedure only with permanent pathology and in many cases with cone biopsy. So patient will be staged before decision. And in the case of endometrial cancer, the mainstay of cervical management will be, and is already, hysterectomy and sentinel lymph node, and that's it. However, this is valid only in trained teams with a specific learning curves, with specialized preoperative imaging, with full equipment, and a specialized pathologist in an integrating team. Thank you very much for your attention. And without surprise, I invite you to the meeting of the ESGO and the end of this year, hopefully after the end of the COVID outbreak. Thank you.